Hello, everyone. Thank you for coming to tonight's program. We've called it Headaches, Migraines, and Concussions with Dr. Mullin. And I will turn it over to her right now.
So hi, everyone. My name is Kate Mullin. I am a neurologist by training. I'm a headache specialist. So what that means is that after my neurology training, I did a one-year fellowship at Montefiore in the Bronx that was designated specifically for headache. And that was about 10 years ago. And essentially since that first day of fellowship, I've been seeing exclusively headache patients for my whole career. So the field of headache and migraine specifically are very near and dear to my heart. It's something that I really think about, how the science is moving forward and how my patients are doing pretty much all the time. So I'm going to talk to you today about different headache types, things to think about when you're feeling a headache, things that you want to pay attention to and tell your doctor when you go to describe your headache, things to worry about, things not to worry about. Then we'll go through some different headache treatments depending on what your headache type is, different modalities and different devices that now treat headaches. And then we'll talk about some of the newer medications that just came through to the market for headaches. And then as we do both clinical practice as well as clinical trials at our office, we'll talk about some of the clinical trials. So for the patients who feel like they've tried everything commercially available and there's nothing that really helps, that's when clinical trials can really play a great role in helping you address your headaches. So I'm going to hopefully share my screen and go through a slide deck. All right, so hopefully you guys can see this. Cassandra, pop in if you can't. So again, I work in Stanford at an institution called the New England Institute of Neurology and Headache, and our sort of sister practice, which is our research department, is the New England Institute of Clinical Research. So we see patients in clinical practice at NEI&H, and then we see subjects in clinical research at NEI-CR. And I sort of supervise in both regards. All right, so what gives you a headache? And that is a very broad question. So there can be certain triggers that can give you a headache. There could be genetic factors that give you a headache. And we'll go into that. But the first question that every time a neurologist sees a patient should be, am I looking at a primary headache or a secondary headache? And let's go through what that means and how to get to that conclusion. So one of the first ways that we as the neurologists or the primary care physician even, or the headache specialist, try to figure out if we're dealing with a primary headache or a secondary headache is by taking a really, really good headache history. So where is the pain? Is it always in the same spot? Does it move throughout your head? Is it 100% of the time right-sided versus left-sided? Those are all really important in helping us figure it out. What's the quality? Is it a throbbing pain versus a stabbing pain versus a squeezing pain or pressure? Those are all also different words that help the neurologist or the headache specialist figure out what headache type we're looking at. What is the severity? So is it mild to moderate, like a 1 to a 4 out of 10? Is it moderate to severe? So it can sometimes hangs out in like the 6 or 7 range, or is it like knock you on your knees, worst headache of your life, 12 out of 10? And that also helps us figure out as neurologists what kind of headache we're looking at. And how does it begin? So does it come on sort of, you wake up, you don't feel great, and then as the day goes on, it gets worse and worse? Or do you wake up or you're doing something, all of a sudden it's 10 out of 10, knock off your socks, and had no build-up time whatsoever? So what happens along with the pain? Do you develop numbness, tingling, nausea, vomiting, double vision, blurry vision? Does anything happen to your eye when you look in the mirror? Or do you feel like you've got something in your eye, but nobody can find it? Lots of time patients go to the eye doctor or the ENT before the headache because of these associated symptoms. And when we get the list of what else happens with the pain, that also helps the doctor. So next time you have a headache, write down how else you feel, because more often than not, it's not just head pain that you're experiencing. What's really important also, any new medications. So something, as common as Plavix, for example, is a really big headache trigger, unfortunately. Any new stressors. So you got a new job, you have a new baby, and you're not sleeping as well. Dietary changes. You just became vegan and you can't figure out what to eat, so you're skipping lots of meals. All that stuff is really important for the provider to ask and for you to be able to supply that information on your first visit. And any current medical problems. So have you recently been diagnosed with a malignancy elsewhere? Do you have thyroid issues? So both hyper and hypothyroid, if not well controlled, can cause headaches. If you have blood sugar issues, doesn't even need to be full diabetes, but some patients are prone to hypoglycemia, so low blood sugar can oftentimes trigger a headache. If you have high blood pressure, if you have standing high blood pressure, that's not often a trigger in and of itself. But if your blood pressure swings and it goes from normal to extremely high or high to extremely higher, that fluctuation can lead to a headache. And any recent illness. So for anybody who has had a sinus infection or even just a regular, sort of viral illness with a sore throat and a cough, most often you get headaches with those. So it's important to pull that out as well. So after we take the history, we do a thorough neurologic exam. Again, this is helping us pinpoint if we're looking at a primary headache or a secondary headache being secondary to something else systemically. We look in the back of your eyes, and what we're looking for when we do that with the ophthalmoscope, we're looking at your optic nerves. And what we're looking for is a blurring or crispness of your optic nerves. We want those nerve borders to be sharp. We want it to be a really well demarcated border. If it's blurry, that means there's an increased intracranial pressure, and generally that means that we're looking at a secondary headache. So it's a really important thing for your initial headache workup to have that eye exam. If you're in the emergency room and it's the worst headache of your life, the doctors will oftentimes do a CAT scan emergently. And the reason for that is because they're looking for blood. Blood is incredibly irritating and very painful because it's not supposed to be there. And a CAT scan would show that right away. Generally, if you're more of an outpatient and we've got the time, an MRI of the brain is a much better picture than a CAT scan. So we'll do an MRI if we've got the time or if they exist in the emergency room, which in a lot of emergency rooms, they do have them now. You don't normally need contrast unless the doctor has something very specific in mind. Just a really good MRI of the brain. Blood work, so as we discussed, an infection, a thyroid abnormality, infections such as Lyme disease can oftentimes present with headaches, especially if it's more chronic. Some autoimmune disorders can present with headache. So we look at that at the first pass just to make sure that all that stuff is in order. And then very rarely as a final step do we do a spinal tap. So a spinal tap looks for a couple of things. One is that we measure the opening pressure. So we all should have sort of a normal pressure that sort of exists in our central nervous system. If something is in there that's not supposed to be in there, that pressure will raise. If we have a leak, so we're losing fluid, that pressure will drop. And both of those things can lead to headaches. We also check for red blood cells because they're a sign of a very subtle leak of blood, which can also be irritating. And we look for white blood cells, which are a sign of infection. So something like meningitis, encephalitis will also lead to increased white blood cells in your central nervous system, and we can pull that out in a spinal tap or a lumbar puncture. And this is why we do all of these tests. We're looking to rule out secondary headaches. So what many people don't know is that acute stroke oftentimes presents as a headache. Sometimes the weakness or the numbness is subtle compared to the head pain itself. So important, those associated symptoms like numbness and weakness are from the headache and not from an acute stroke. A mass lesion, a lot of my new patients want to make sure they don't have a tumor, whether they have a family history of it or it's just something that they've always been worried about. When you have a headache that's new or different or worse, people often jump to the worst conclusion, which is a mass lesion. As I said, high blood pressure. So if you've got a really big swing in your blood pressure to something called hypertensive urgency or hypertensive emergency, that can lead to a pretty severe headache. We want to make sure you don't have an infection like meningitis or encephalitis. There's a herpes complex that can live in your brain and in your spinal fluid that can lead to a really severe headache. And blood. So specifically aneurysmal bleeds. Sometimes they can be subtle and not dangerous, but oftentimes they can be incredibly dangerous. So if someone presents with what's called a thunderclap headache, you go from 0 to 10 in seconds, and it's the most severe pain you've ever experienced. We always worry about bleeding, and that's when we get a CAT scan and then potentially a spinal tap if we don't see the blood and our suspicion is high enough to look for red blood cells in that. So when you go to your neurologist, your headache specialist, or even your primary care doctor, because sometimes people present there first, what we're looking to do is get a really good history, get a really good exam, get some baseline pictures and blood work, to make sure that we're not looking at a secondary headache. Because if we rule all that out with all of our tests and questions, we're left with primary headaches. And primary headaches, by definition, are not secondary to an underlying condition. That no matter what you fix or what you do, these headaches exist on their own independently. And the ones that we see most often in clinical practice are migraine, tension type headache, and cluster headache. Most prevalent in the general population are tension type headaches. However, for the most part, they are normally mild to moderate and dealt with at home or with a PMD. As a headache specialist, I see migraines above and beyond. And I do see cluster headaches. They're not very prevalent, but they are an incredibly disabling condition. So I always give cluster headaches a word during these talks because lots of patients don't know what they have and they don't see a doctor for it. So it's important to just put it out there in case you have a cousin or an uncle who's got cluster headaches. So let's say we've ruled out your secondary headaches and you're convinced through your pictures and your lab work and the history taking that you have a primary headache. And then how can you figure out which headache type it is beyond that? That's all done based on the history. So it's all about what the patient tells you they experience when they're having their headache. So for migraine, they're predominantly female as a patient population. They're long headaches. These are not 15, 20-minute headaches. They're not even 1-2 hours. At minimum, migraines last 4 hours and they can be as long as 72 hours. So these are headaches that you go to sleep with and when you wake up the next morning, they're oftentimes still there. Migraines are moderate to severe in intensity, meaning most migraine patients can't just keep doing what they were doing. It's too severe to just push through it. They're throbbing, so it's not a pressure, it's not a stab. Patients oftentimes will say it's a pulsating quality. I feel like I can hear my heartbeat in my ears. That's the throbbing sensation. They'll put their fingers on their temple and say they can feel their heart beating in there. That's what throbbing sounds like when someone describes throbbing. Migraines are usually one-sided. That's not to say that they're always the same side or that they always stay on one side, but oftentimes patients will say, it's worse on my right, but then it spreads to my left. But then the next headache I have will be worse on my left and spread to my right. But at some moment in that migraine, usually one side is worse than the other. It should not be side locked, meaning if a patient says to you, 100% of the time it's on my left, you might want to think about a different headache than migraine. Usually there's nausea involved, not always to the point of vomiting, but most migraine patients are not hungry. They're not sitting down and eating dinner when they're having their migraine. They just kind of they have a food aversion while they're in their pain. They have light or sound sensitivity. So patients will often say, I just wanted to go to a dark, quiet room. That's because the light bothers them and because sound bothers them. You'll also find on taking a history that smells. Patients get really sensitive to smells. When someone's cooking in the house, they find the odor really noxious. Someone walks by with a really strong perfume, that makes their headaches worse. So everything is sort of a heightened sensitivity and made worse with physical activity. So if you're having a migraine and you try to clean the house or, go to the gym, most patients find that trying to be physical actually makes their head pain worse, which is why they don't want to do jumping jacks in a quiet, dark room. They want to lie down in a quiet, dark room. So tension type headaches characteristics are generally very different, which is a nice way to help differentiate the two when you're taking a history in clinical setting. So unlike migraines, which are moderate to severe, the severity of tension type headaches is mild to moderate. So these are headaches that most patients can generally push through. They can go to work, they can go to the gym, they can keep, whatever social engagement they have. They feel it, they don't love it, but it's not disabling to the point where they have to cancel plans. As opposed to a throbbing, tension type headache patients describe more of a pressure, sort of a tightening band around the forehead and the temples, like someone squeezing their head in a vice is oftentimes how it's described. It's bilateral, so that pressure is coming in from both sides. The variety of timing of tension type headaches is very varied. These can be short. So oftentimes patients will only say, it lasted 30 minutes and then it went away. But they can also be very, very long. Sometimes you can go a stretch for 6 or 7 days where you just have that sort of mild pressure in your head that won't go away. And that's also typical for tension type headache. But you don't usually get light or sound sensitive in tension type headaches. There are certainly exceptions. I will have some patients with tension type headaches. Your head hurts, you don't feel great, you don't want a kid screaming in your face. So there can be some sound sensitivity, not normally light. And usually there's no nausea and there's definitely no vomiting. If a patient vomits with a headache, It's really migraine until proven otherwise. So cluster, and as I said, it is by no means very prevalent, but because it is absolutely so disabling and so painful, and because not enough cluster patients come to doctors, I always like to talk about it just briefly. They don't come to doctors because they're predominantly male. These patients they just think that it's some weird, terrible headache, and no one ever talks about it. So they think that they're alone in experiencing it, which is why they don't seek healthcare. So these headaches are side locked. So the way that I mean, unilateral, yes, like migraine, but always the same side. And usually it happens around and behind their eye. So they'll say, there is a severe stabbing, piercing pain always around my right eye. They called it an ice pick headache at one point because it really is such a direct, distinct pain. When they have that pain, most patients, if you looked in the mirror, unlike migraine or tension type headaches, that side of their face looks different. The eye will turn red, their nose will run, they'll get tearing down that side of the face. Sometimes they flush or sweat on that side of the face. So cluster headache, if you go and look in the mirror, you actually do notice the difference in the sides of the face. Luckily, these attacks are shorter than migraines and tension type headaches. So 15 minutes to 3 hours is the diagnostic criteria. On average, they last about 45 minutes. Patients can have multiple attacks a day. So with migraine, it's one and done. They don't just stack up on each other. But tension type headaches, they can have up to 8 attacks a day. And unlike migraine, where you want to lie down, the pain is so severe and so exquisite that these patients oftentimes pace and get very restless. These attacks more often than not happen in the middle of the night, 2 o'clock in the morning. So they call them alarm clock headaches. Patients say they can really set their watch to when they're going to wake up with their cluster headache. And you can imagine this 10 out of 10, incredibly severe pain, also depriving you from sleep every night because you're waking up with the attacks. So that's why this is such a disabling condition, because if they come at them 3-4 day at a time, waking up in the middle of the night, 10 out of 10 pain, sometimes lasting up to 2 hours, and it really gets to you. They cluster because most of the time, if it's episodic cluster, they'll have maybe 2 weeks, 2 months where they have the attacks, and then they can go 6 months, sometimes years without them. And then slowly but surely, another cluster episode starts, and then again, they go weeks to months with the attacks, and then they fade into the background again. More often than not, cluster headaches sort of spring up when we do daylight savings. So in March and October, we start keeping our eye out for cluster patients. That's thought that's something to do with changing the clocks and circadian rhythms, much like cluster headaches happen sort of on an alarm clock setting. We think that something about changing our alarm clocks triggers the cluster patients. So if you have an aunt or an uncle, more likely an uncle, who has tearing and drooping in the eyelid and has to leave and pace the room because he's in so much pain, send him to a doctor, because those are cluster headaches, and we actually do have treatments for them that make you feel considerably better. So let's talk about treatment for migraine, because as I said, as a headache specialist, that's probably 90% of my practice. So there are non-pharmacologic, so there's things that we can do that don't involve medicine at all that can help reduce your headache frequency. So first and foremost, migraine brains like things to be consistent and predictable. That includes a sleep schedule. So that also includes weekends, holidays, times when you would normally sleep in. Unfortunately, migraine patients can't overdo that. So I say, give yourself an hour extra on the weekends, but you can't have a 4-hour swing from your weekends to your weekdays, because that's going to trigger a headache. A regular meal schedule. So you don't want to fast, meaning, skip meals for hours on end, because that's going to plummet your blood sugar. And then potentially carb load, where you shoot up your blood sugar. Those giant swings in blood sugar can really affect your headaches and trigger a migraine. The ideal is multiple small meals throughout the day that are protein rich. Protein gives you a nice stable blood glucose level, and that's what you really want to maintain throughout the day. If you have found a trigger, and people ask me all the time about, can I have a list of triggers? And unfortunately, every human is different. Every dynamic inside our bodies is different. There are some more obvious ones, like really sugary alcohol. MSG is a big one. So anything that's got like a flavoring packet probably has MSG. Nitrates, so things that are preserved. Those are sort of more common ones that I can say with confidence we should probably avoid as migraine sufferers to help reduce your frequency. Stress management. So I don't say stress avoidance because, first of all, this last year, nobody could avoid stress, but just in general, right? There's going to be family things that are stressful. There's going to be work things that are stressful. We can't just run away and hide, but what we can do is manage them and cope with them in the healthiest way possible. And there are certain skill sets that can be learned, like cognitive behavioral therapy and biofeedback. We have two really good neuropsychologists in our office that practice both of those things with our patients, so that when life throws you a curveball, when life gives you an extra amount of stress, you can handle it so that you don't internalize it and doesn't translate into a headache. Physical therapy goes hand in hand with migraine. I would probably say 90% of my patients have tension in their necks and upper backs and shoulders. There's a known correlation between how high our shoulders get and how many headaches that we have. So it's a conscious effort to pull your shoulders down, pull your shoulders back, align your head with your core. And there are physical therapists that can help teach you different techniques so that you can remind yourself to do that and do that more often. We weren't made to keep our chins and our heads inches away from our neck and our core. So it's all about realigning yourself and recentering yourself so that your neck and your shoulders don't have to take the weight of your head all by themselves. Medical massage, so same idea. We have a physical therapy and massage therapy connected with us. So just like we've got the neuropsychologists, we have PT and massage for the same reason, because so many of our headache patients have so much tension. And sometimes, unfortunately, if you do the massage wrong, it can actually trigger headache. So it's really important to go to somebody who knows what you're going for, knows your trigger points, and knows where to push and where to be gentle. And then finally, sort of getting closer to medicine, but not quite medicine, are vitamins. So there are two supplements that are naturally found in our bodies, so magnesium and vitamin B2, which is also called riboflavin, that have in double-blind placebo-controlled trials been shown to benefit and help reduce migraine frequency if you take them regularly. So again, these are things that are found naturally in our bodies. We have rarely any side effects to them. If you take too much magnesium, sometimes you can move your bowels too frequently, which some patients don't enjoy. Vitamin B2 is virtually side effect free, except it will change your urine and make your urine and make it look more orange. Some patients worry that that's dehydration, but it's not. It's a breakdown of the vitamin that just gets excreted in your urine. So that was medicines or things that you do and supplements that you try to reduce your headaches. You could do all of those lifestyle modifications. You can be totally zen and eating all of your protein and sleeping 8 hours, weekends and weekdays, but there's no cure for migraine. And the odds are, if you have a history of migraine at some point in your life, you're still going to have another migraine. And that's why we always give our patients an acute migraine treatment, and acute treatment being something to take at the onset of your next migraine. Triptans are the sort of oldest, most tried and true medications that we've used for migraines. Have been around since the early 90s. Sumatriptan, or Imitrex, was the first one developed. Has been really the go-to for most primary care doctors for decades, but others have been formed since then for a variety of reasons. So sumatriptan kicks in very quickly and also goes out of your system pretty quickly, and that's great for brief, intense headaches. But as we learned over time, not everyone's headaches follow those rules. Some of them come on slowly and last much longer. So that's why we started changing the half-life of these triptans to make them better tolerated and to help them last longer for those headaches that bounce back 6-8 hours later, and the sumatriptan is well out of your system. Something like elatriptan or naratriptan would still be in your system. So we tailor the triptans based on the story that the patient provides about how their headaches come on and how long they last. There's always the non-prescription anti-inflammatories. So Aleve, Advil, and naproxen still very much have a role in migraine treatment. We always try to start with a specific medication like the triptans because they work primarily at the beginning of a headache. They're less effective if you wait too long, but there's always what's called a rescue or even conjunctive use of the non-steroidal anti-inflammatories. If you caught your headache too late, or if the triptan worked, but it's hours later and you feel like the headache is coming back, that's normally when we use something like naproxen or Motrin. And muscle relaxers, for all the reasons that we said. Our shoulders and our neck get very tight, oftentimes right before a headache starts or during a headache. And it's really beneficial if you just reduce that tension and relax those muscles, because unfortunately, sometimes they feed into each other and one just gets worse as the other one gets worse. So there are very new medications. So if you haven't been to a neurologist, and for these medications, you probably actually need to see a headache specialist specifically. You might not have heard of the newest alternative acute medications. So it was triptans was all we had that was disease specific for 30 years. But just this past year, we've got 3 brand new medications that are not triptans. So the first one is called lasmiditan or Rayvow. So triptans are 5-HT1B serotonin receptor antagonist. Rayvow is a 5-HT1F serotonin receptor antagonist. And the reason that is important is because the 5-HT1B receptors vasoconstrict. They shrink your blood vessels. And if you have a history of a heart attack or TIA or a stroke, we can't risk you shrinking your blood vessels, so you can't take triptans. However, the 5-HT1F receptor antagonists do not shrink your blood vessels. So if you were told, ever since your heart attack 20 years ago that you can't take an acute migraine medication, now you can. So that's been wonderful for people with cardiovascular risk factors. There is one caveat with Rayvow. You cannot drive within 8 hours of taking it. So for some patients, that's fine. They're going to be home anyways because they weren't feeling well. But for others, if the goal is to take your medication and then keep going about your day, which might involve driving, then you have to come up with a different acute medication plan. Another class are the gepants. So these are also brand new. So for people that have been to the doctor recently or have seen commercials on TV, CGRP is sort of the new rave in migraine medications. We see a lot of commercials on TV for the once monthly injectable CGRPs, which we'll go into a little bit later, but those are preventative medications. These are oral acute medications to take as you get your headache, just like you would take a triptan or an NSAID. The 2 that are out in the market now are ubrogepant or Ubrelvy, which is Allergan's medication, and rimegepant or Nurtec, which is Biohaven's. So again, these are medications where your headache starts, you take your, let's say, Ubrelvy. If the headache's not gone in 2 hours, with Ubrelvy, you can take another dose. With rimegepant, it is a 24-hour dose, so it's just a one and done. These are really effective medications, incredibly well tolerated, and also don't vasoconstrict. So if you have a history of any cardiovascular or cerebrovascular risk factors, you don't have to worry about these medications. Also, they can be taken conjunctively with triptans because they work so differently. It's a nice 1-2 punch for patients who get some benefit with triptans, but there's room for improvement. So here is the whole list of all the meds that we just talked about. So as you can see, the triptans have really expanded much beyond Imitrex. And what's nice to look at here is that there are the different formulations. So we talked about nausea and vomiting being a big part of migraine. Because of that, pharmaceutical companies realized that everything couldn't just be a pill. So there's a triptan max salt that dissolves underneath your tongue, gets absorbed into your oral mucosa so that it doesn't go through your gut. And Nurtec, one of those new gepants, same thing. It dissolves under your tongue almost immediately. So you don't have to worry about swallowing it and potentially throwing it up later. Nasal spray, same idea. So there's multiple nasal sprays in headache so that you don't have to worry about swallowing a pill. And injections, so the injections of Imitrex and Toradol, which is oftentimes given in the emergency room, those would be really safe for the patients who are, vomiting from the beginning, or the cluster headache patients use injections a lot because their pain is so severe, so fast. That's really when it's the most effective. If the patient ramps up to a 10 out of 10 so fast that you just don't want to wait for a pill or nasal spray to kick in. And then finally, there's an oral powder that I really like called Cambia. Diclofenac is the pill version. It's really nice for adolescents. It comes in like a little drink, and you just do it real quick, and it generally kicks in faster than a pill because of its formulation, and it's really well tolerated. Okay, so there are some patients where they do all their lifestyle stuff, they're taking their acute medications, but they're coming to me, they're saying, Doc, I'm taking my acute medications 8 days per month. Or, I'm only taking it 3 days per month, but they're not working, and I've had to, I might get fired because I'm missing so many days of work. That's when we say, okay, you're having too many headaches, or we're not controlling your headaches well enough. And that's when we talk about prevention. So what we did when I first started my career, and pretty much until Botox, which was about 10 years ago, were oral migraine medications, none of which were made for migraine. So as you can see, the categories: antidepressants, blood pressure medications, seizure medications, and then some other sort of one-offs. We were using medications for decades that were not made for headache. What happened was patients were taking these medications for their other conditions, and they were realizing that their headaches were getting better on these medications. So then clinical trials were done to really show that even patients that only had migraines and not those other conditions were benefiting from these medications. So nortriptyline, amitriptyline, and Effexor are the antidepressants that have the strongest level of evidence. We do use other medications, but those are the ones that have panned out in clinical trials to be the most effective. Blood pressure medication, so propranolol is really one of the first ones that a doctor oftentimes prescribes. Nadolol, timolol, metoprolol, so those are all what's called beta blockers. That's a big category. Rapamyl is a calcium channel blocker, oftentimes used in cluster headache, but sometimes in migraine. Canosartan and lisinopril, which are ARBs and ACE inhibitors. Seizure medications, which makes patients nervous. So you always have to explain as the provider and as the prescriber that you're not going to give them seizures by starting or stopping these medications. You don't have a conversation and they pick up their prescription, they're going to panic that you're treating them for something that they didn't know they had. So Depakote is a really great medication, but it's got pretty lousy side effects. So I try not to prescribe it as a first pass. Topamax, gabapentin, zonisamide, lamotrigine, and pregabalin. And then other medications. So Namenda, which is sort of notorious Alzheimer's medication, actually has pretty good evidence in migraine. Methergine, which is a very old medication that we use sparingly, but is very effective. And indomethacin, which is a very specific NSAID that helps in very specific headache types. So we did all those medications for decades. And then in the early 2000s, Botox came into the picture. So same idea, people were getting cosmetic Botox in their foreheads, and those that had migraines were like, wow, my migraines are better when I get my cosmetic Botox. So what they did was they did a clinical trial called the Preempt that did very migraine specific. So forehead, the temples, the back of the head, and the shoulders. You can't see, but there's 3 little dots going along the shoulder blades. So called the Preempt protocol, and they did that in patients that only had migraines. It was not for cosmetic benefit, and it was found to help reduce chronic migraine. So chronic migraine by definition is 15 or more headache days per month. It was not shown to be effective in patients that had less than 15 headache days per month. So it is sort of a specific subset of migraine patients. But it was wildly attractive to lots of patients. You know, they were tired of taking pills that weren't made for their condition, that had side effects. You know, you take a blood pressure medication, you're going to probably drop your blood pressure. If you take an antidepressant, sometimes you gain weight, sometimes you get sleepy. So this was a great improvement in our preventative options. We could do this once every 3 months, as long as the patient wasn't afraid of needles. Most were really thrilled to try it, and potentially start to reduce some of those oral medications that they were taking. So as I said, 10 years ago, it's covered by insurance. So all you have to do is show the insurance company what the headache frequency is and that you've tried and failed some of the other oral medications in the past. It's 31 injections. So those little dots there's 31 of them. It sounds like a lot, but really you do it in the office. You know, it's done in a very controlled environment. It can probably take max 5 minutes as long as it's being tolerated, and we can just do it in one pass. Minimal side effects. So again, because it is working on the muscle, so it works to relax the muscle that it's injected into. That's all it does. So other than maybe some bumps where the medicine goes in, sometimes there's bruising if a blood vessel is nicked, you don't get sleepy, you don't gain weight, your blood pressure doesn't drop, all of the speeches that we used to give about the oral medications, you don't have to give that with Botox. The only place where you can really tell Botox was administered is the forehead, and that's because of those frontal injections. You need to talk to your patient about, how much freezing they want, because the headache protocol is pretty heavy. So sometimes I do tailor a little bit because patients still want to raise their eyebrows and show their kids that they're mad at them. So that's the only place where you can really tell that Botox has been administered in a headache patient. As a headache specialist, more often than not, I've had my patients come to me and they're already on Botox and they're already on Topamax and propranolol, and they're doing all the lifestyle things and they're taking all of the acute medications that I've come up with, and they're frustrated and they say, okay, I think I've tried everything. What do I do now? So one of the things that have come out in the past 5 years are these devices. So devices are wonderful. Again, much like Botox, there's no systemic side effects. So they're not putting a chemical in their body that's going to affect their metabolism or their mood or their sleep. It really works more directly on the pain pathways externally to help either prevent the headaches or stop them. So the cephally device was initially made for prevention to be worn for 20 minutes once a day. It's got little electrodes on it that lay right above your eyebrows. And then you push the button in the middle and there's a buzzing sensation. Some patients loved it and found it very relaxing. Some patients find any sort of stimulation to the area where they're sort of most sensitive to be incredibly irritating. So it's not for everybody. You need a prescription for it, but then you do purchase it. They do give you your money back in 90 days, I think, if you don't like it. GammaCore works very differently. So GammaCore is actually triggering your vagus nerve. So you can see the man got the device right along his neck. That's where your vagus nerve lives. Your vagus nerve carries a lot of pain sensations. And what it does is it's to be used both for cluster headache and for migraine headache when the headache comes on. And then Nerivio, so also an acute intervention, goes on your arm. So what happens, this is also an acute therapy. So when you get your headache, you put the Nerivio on, it also sends sort of a buzzing, tingling sensation. And this is sort of the gateway that, essentially if you pinch one place, you feel less pain in the other. That's kind of the layman's way of describing how Nerivio works. It overrides the pain fibers and sensations that your head is sending because the arm is sort of busy with all this buzzing. Same idea as a cephally. Some patients found it's not necessarily relaxing, but really innocuous, and some really just couldn't tolerate the level of buzzing required to stop the headache. But nice alternatives, and for the most, devices are inherently pretty benign. So if you feel like you've tried enough of the pills, you want to do something different, these are really nice options. So here are the CGRP monoclonal antibodies that I was referring to earlier. So in the past 2 years, we have 4 brand new preventions that work completely differently than anything we've had in the past. They are CGRP monoclonal antibodies. So CGRP is a neuropeptide that we all have circulating throughout our system. It has been found that if you have a history of migraines and you get injected with CGRP, you will trigger a migraine. If you have a migraine and you're given a triptan, your CGRP level will drop. If you have chronic migraine, you have elevated CGRP levels compared to patients that don't have chronic migraine. So luckily, pharma and scientists said, well, what happens if we block CGRP? And that's exactly what these medications do. So Emgality and Ajovy find CGRP circulating throughout your body. They bind to it, and then when CGRP goes to dock into its receptor, it can't because Emgality and Ajovy are there in its place, so it can't trigger and activate the headaches. Aimovig binds to the receptor of CGRP, so same idea. The ligand or CGRP is floating around, it goes to hit the receptor, but Aimovig is already there, so it can't activate. Those 3 are injectables, so they're sub-Q injectables that you can do at home. Emgality and Aimovig are once a month. Ajovy is once a month, but can also be once every 3 months if you're willing to do 3 injections at once. And Vyepti, that final one, which is the newest, is an infusion once every 3 months. So there are a little bit of restrictions and limitability in terms of who can get Vyepti because you have to have access to an infusion center and infusion suite. We do have that luckily at our office, so we do offer Vyepti to patients. But really great because it's the first time we've had migraine-specific preventatives pretty much ever, because all those other pills, right, were they made for other conditions, as was Botox. So this is thrilling. It's really changing the face of how we treat migraine. And this, again, this does not have to be chronic migraine. Lots of people think that in order to qualify for these medications, you have to have chronic migraine. You do not. You can have as little as 4 migraine days a month. And because there's 4 of them out at the same time, they're highly competitive and therefore not incredibly expensive. Most of them still have copay assist plans where you can get them for as little as $0 per month if you have commercial insurance. So here's what they look like. So they have these auto injectors, they're called. They're spring loaded. So some of them have the option of an old school syringe, which some patients are more comfortable with. But when you do these auto injectors, you never have to see a needle. You just hold it up against the part of your body that you want to inject into. Usually it's somewhere fatty, like your belly or your outer thigh. You hold it up, you push the button, you wait for the medicine to plunge in. The needle retracts and you never have to see the needle or plunge a syringe, which lots of patients get a little bit squeamish about. Okay, I also have patients that come and say, I've been on Aimovig, I've been on Emgality, insurance doesn't cover Vyepti, I'm already on Botox, I've been through all the oral pills, what do I do now? And that's when I'm so grateful for having a clinical trial program as part of our practice, because that's the kind of patient that's really, it's time to see what's not out there yet, but what might be right for you. So the benefits of rolling clinical trials. So you have access to medications that have not yet become commercially available. You get additional care. So when you enroll in a clinical trial in our practice, you see a neurologist every time you come in, which is sometimes as much as once a month for years. You get a neurologic exam, you get blood work, you get extra special treatment and care. You're helping contribute to the future of science. So migraine is genetic. So if you are suffering from migraines and really having a hard time finding something that works for you, you might have a niece or a daughter or a granddaughter who's going to be you in 40 years. And it's nice to sort of help pave the way for them so they have more options for their treatment path as their migraines develop. You're always compensated for your time and travel. So if you are, taking time out of your day, we will compensate you for that time. We will feed you while you're in the office. And the knowledge gained from clinical trials could not only directly benefit your condition, but also generations to come. So as I said, this is a genetic condition. So generally, when you do a clinical trial, sometimes it's selfishly because you want to find something that works for you. But more often than not, the people that enroll are altruistic and they're just trying to help figure out the science of something. They're trying to help figure out how somebody else can benefit from the medicine that they potentially helped come to the market. We did clinical trials for most of those CGRPs. We did clinical trials for Botox. And if you didn't do them, and if subjects didn't enroll in them, we want to have those available to everybody now. So that's saying a lot. Right now, we have a ton of trials in headache medicine. So we have trials right now, both for adolescent migraine, both acute and preventative treatments, for pediatric migraine, both for episodic migraine and chronic migraine, as well as cluster. So if you feel like you've been through it all with your general doctor or your neurologist, your headache specialist, it's worth calling our office to see if we've got a trial that's appropriate for you. Because actually, in my years at this practice, I don't think we've ever had so many headache trials. So now would be the time to call or to go to neicr.com and see what trials we're enrolling in. We don't just have headache trials. So we also have trials ongoing right now in dystonia. We have a couple going on in Alzheimer's disease. We have some MS trials as well as Parkinson's. So even if you don't suffer from headaches, or if you've got a family member who has one of those other conditions, I encourage you to go on to NEICR and look at the trials that we have ongoing now. We update that really frequently, so it should be a pretty accurate description. And if you see something that you question whether or not you'd be appropriate for, it's always worth giving our office a call. We're at 203-914-1903. We have a large research staff that, each one is dedicated to certain trials, so they can give you the in and outs of what's required from you, what's required from us, what you would get out of it, your odds of being on the placebo versus the medication. All of your questions can be answered by our staff readily and easily. So this is when I generally take questions. Before, I haven't looked at the chat yet to see how many questions there are, but I did have 2 questions that came in before the start of the talk. So I was gonna answer those quickly. So there's a lot of questions actually in my practice about headaches and the COVID vaccine. So I did want to touch briefly on that because it's really important. As of now, I'm in New York, but the same is true in Connecticut. The COVID vaccine is recommended to anybody who's 16 or older. There's 3 out there commercially available: Moderna, Pfizer, and the J&J. They all have headache as a possible side effect. And having had the vaccine myself, I had a terrible headache. I'm not going to pretend like that's not a very likely side effect. Things that you can do to potentially prevent that side effect as best as you can. You want to hydrate excessively before you get your vaccine. You want to get a really good night's sleep. That can help. Most say try not to take NSAIDs until at least 24 hours after your vaccine. And they definitely say not to pre-medicate. So it's tempting to take a bunch of Advil before you get a vaccine, but they're really asking that you not do that. After 24 hours, you absolutely should take NSAIDs and really suppress your symptoms as best as you can. There's no harm in that. If that doesn't work, you should call your headache specialist or your doctor about maybe something stronger. The COVID vaccine is intentionally inflammatory, right? It is triggering our immune system in a good way so that we activate and we create these antibodies. But whenever you have something inflammatory in your body, if you have a propensity to headaches, you're probably going to get one. If you don't have propensity to headaches, you might get one. Having said all that, as a scientist, I still encourage you to get vaccinated. If you are one of my patients, I will work you through what to do if the headache comes and we can't make it go away. I've done that with dozens of patients so far, and I just hope that the fear of the headache worsening doesn't prevent anyone from getting the vaccine, because once you're 24 hours out, there's nothing that we can't do to stop it. You just have to sort of grit and bear it for that, hopefully sleeping 8 hours of sleeping and then a couple more hours during the day. But I still do encourage, despite the fact that it might make your headaches worse, I'm not going to pretend it won't, to get vaccinated and let me help you deal with it on the back end. And then another question, which is specific to a very rare headache type. So hemiplegic migraine, we don't talk about in sort of these broad talks because it's very rare, and it's a very specific, fascinating disorder. So you get migraines with aura. So for some patients, the aura can be flashing lights, or they can even have tingling. Sometimes patients have difficulty communicating or understanding. Hemiplegic migraine, their aura is a weakness in one half of their body. The first time you get it, it's obviously incredibly scary. It looks very similar to a stroke. It is sometimes familial. So if you know that there's a family history of it, it's actually a little bit less scary because you've seen it in the past. Treatment for hemiplegic migraine is a little bit different. So we oftentimes use traditional medications that we used that I discussed already, but these four are sort of specific to hemiplegic. So acetazolamide, rapamycin, flunarizine, and lamotrigine don't have a ton of great evidence for migraine, but they do seem to have specific sensitivity for hemiplegic migraines. And I personally would also try to do a CGRP. So, CGRPs just tend to limit and blunt inflammation. So I do think that it's worthwhile for hemiplegic migraines to try CGRP monoclonal antibodies and see if it helps reduce their frequency. Okay, so that's all I had for sort of the pre questions. I'm happy to take others as they come in.
So we've got a few questions in the chat. The first one is, will you be discussing concussions, specifically, I'm not sure how to read this word, one-entation or on-entation difficulties years later?
So no, this was more geared towards primary headaches and migraines. I can't see the question that you're reading, Cassandra, to know what that word is.
So orientations. Apparently I can't read. So
like disorientation?
Disorientation, probably.
So there is something called post-concussive syndrome where so the average time to heal from a concussion, to completely recover from a concussion is about 3 weeks. But there are patients who have symptoms such as disorientation, dizziness, headaches, cognitive fog, 3 months or longer, and that's called post-concussive syndrome. We treat that differently. We generally try to help concussions heal on their own because the majority of them will just get better with time. But when you do have symptoms beyond 3 months, that's when we start using medications. Sometimes we have neuropsych testing go on so that we can really hone in on exactly where your deficits are and do different therapies to help improve those deficits.
Okay, so the next question I see is, I've been experiencing stabbing pain above my ear right side at the same time having headaches behind my left eye. Not sure if it's cluster headaches with a migraine.
So if they happen together all the time, it's incredibly unlikely that you're having a cluster and a migraine concurrently. More likely it's a migraine. So as I said, when migraines, they choose a side, but more often than not, that's brief and they're sort of everywhere eventually. Stabbing pain with a migraine is actually pretty common. So it's called the jabs or jolts or primary stabbing headaches. If you have migraines, you have a much higher propensity of having stabbing headaches. Essentially, when you're in the middle of a migraine, much like I said, light, sound, smells, you're hyper attuned to them. The same is true of your nerve endings. So more often than not, your nerves feel incredibly raw and fiery, and sometimes that can present as a stabbing sensation really anywhere in your head.
Okay. The next question is, what if you suffered from migraines your whole life and suffered a brain bleed a few months ago, and headaches are bad and cannot take NSAIDs after the COVID vaccine?
So is the question whether or not you still get the COVID vaccine?
I think the
so you can't take. So I think that the point is that they can't take NSAIDs because of the bleed, because NSAIDs can increase your risk of bleeding. If that was the case, then I would talk to my doctor about other things that can be done to help alleviate the symptoms of the COVID vaccine. As far as I know, the brain bleed does not prohibit you from getting the vaccine. And I still think it's probably worthwhile getting. You can always take migraine specific medication. So something like the triptans or the G-Pens are perfectly safe to take after the COVID vaccine and won't increase your risk of bleeding, won't complicate the history of the brain bleed.
Okay. And the next one is, are there any new treatments or advances with NDPH?
So NDPH is a very specific headache called new daily persistent headache. That's what it stands for. It's a headache that happens in a patient who felt totally fine their whole lives, never had headache history. And then one day, sometimes because they have a viral illness, sometimes because they have a head injury, sometimes because they had a major life event or surgery, they develop a headache, and it literally from the minute it starts never goes away. It's a very refractory headache type. It's also very rare. So in terms of clinical trials and studies, there's not a lot done. Much like hemiplegic migraine, if an NDPH patient hasn't been to a doctor to try the CGRP monoclonal antibodies yet, there's no trials to prove that it works, but it's safe and it's effective in migraine. And I would definitely try it in the new daily patients.
Okay, that's the last of the questions in the chat. Does anybody have any other questions for Dr. Mullin? If you can type them up in the chat, I'll read them out. Otherwise, Doctor, can they email you with any questions afterwards?
Absolutely, yeah. So I'm at kate@neinh.com.
Okay, I'm going to type that into the chat.
Happy to answer any questions. And again, if you're not sure, but you're interested in clinical trials, please give us a call, 203-914-1903. We're happy to just run you through what we got, even if you're not a perfect match.
So it looks like no one has any other questions. So if there's anything else you want to add?
No, that's all. Thank you guys for listening. Again, keep your eyes open for any red flags. And, as I talked about, the things that make us worried. And if you have an uncle with cluster headaches, please make sure he sees a doctor because they're really quietly suffering greatly.
Thank you so much, Dr. Mullin. It was
my
a great
pleasure.
presentation.
Thanks for logging on, everybody.
And thank you everyone for coming. Have a great evening. Good night, everyone.